Good morning. Distinguished orator of the day, Professor K. Ganapathy, Dr. M.C. Vasudevan, Dr. Krishna Kumar, Dr. Anil Pandey, ALNC team, and the faculty who have come from various places. Special welcome to Dr. Ravi Ramurthy, meeting him after such a long time, delegates, and my colleagues from VHS. It is indeed a pleasure and honor to preside over the 25th ALNC oration. What better way to start the day's proceedings than to hear a lovely musical performance by the Akkarai sisters to calm the body, mind and soul and to re-energize ourselves. This is a day which we look forward to every year at VHS, and over the past 3 days I heard an excellent endoscopic neurosurgery workshop has been conducted with several patients successfully been operated. Many stalwarts have demonstrated their skills and given superb lectures, and I'm sure the delegates are having a significant learning experience. I'm also extremely happy that Dr. Mani Veeravan was honored in this workshop. Both Mani and myself were junior doctors in the Department of Surgery at VHS way back in the 70s. And we used to discuss what we are going to do with our careers. And we went in 2 different career paths, and he has made a very significant mark. Yesterday, I had a small chat with Dr. Anil Pandey, and he told me that for the first time a retractorless endoscopic spine surgery was done, and it's indeed a significant event in the history of VHS. My congratulations to the ALNC team for conducting because conducting a live workshop brings with it very unique challenges. And year on year, for over a quarter of a century, the ALNC department has done this with consistency and efficiency. This has been a huge learning experience, and that has benefited the upcoming neurosurgeons. The consistency can only be, this kind of consistency can be only maintained for 2 reasons. One, enormous respect they have for the initiator, Professor B. Ramurthy, and second, total commitment to the cause of neurosurgery. Coming to today's oration, I am quite intrigued by the title, Good Death in Neurosurgery, because way back, I remember when Professor B. Ramurthy was head of the neurosurgery department at the GH. My uncle was also a neurosurgeon there, and commonly it used to be said when he started the department, when he used to do rounds, and only one question he'll ask the sister, how many patients in the ward? They say, 20, sir. How many of them are conscious to discharge them? This is what was there, and where we have come from there to now, that we are actually being able to go into the brain without even opening the skull through endoscopy. I've known, as I said, the title Good Death in Neurosurgery intrigues me. I don't know what's in store, but I can say Professor Ganapathy and myself go back a long way, for over 4 decades. And he took neurosurgery as his mission in life, and I know indeed he is the apt person to deliver this oration. For over 4 decades we've had the privilege of interacting. While we were together in a society, a few doctors joined together and said, how can we spread medical education, keep people abreast of what's happening? And we started a society called Society for Medical Learning Resources and Transfer, SMLRT. During those meetings, I could see the extraordinary insight Dr. Ganapathy had about spreading the knowledge to current and the next generation. Very precise, few words, but every one of those words will be very, very important, and it will lead to some action. And after almost 30 years, he still had the records of what we did. And very recently, he has published a paper on how before the libraries, before digitization, how we could spread medical knowledge. And that's something very unique. I was quite astounded when he sent me a copy of the paper and said, this is what you're going to... I said, this is a long time ago, but it is very relevant now because it tracks the journey of how education was spread at that time. And I also remember very well about when he was doing his PhD. So one day he called all of us friends and said, all of you sit down here. I'm going to go for my PhD viva and I'm going to show you what I'm going to speak there. And it was on CT scan, that very unique at that time. It was very beginning. And then for the first time I heard the word Hounsfield units. And he's the one who told me about what it was. Just to say that there was no necessity for him to call us and tell us about what he had done, because he could straight away gone to the viva and it would, of course, he would have scored beyond anybody's imagination. So it gives me extremely a sense of joy that he is here today. Now, death for all of us is when someone is breathing no more, for ordinary people. But over the years, we hear of the word brain death. And one starts to wonder, who will decide the person's brain is dead? It is a word the family has to understand, accept, and take very critical decisions. I'm not sure whether today's lecture is going to explain that concept, as I mentioned earlier, but I'm intrigued by the title and as eagerly waiting for the oration as you are, because I remember Dr. Ganapathy being involved in this matter of discourse over brain death for many years, and I've heard him speak about it and explain about it sometime. I am sure that knowing Dr. Ganapathy well for all these years, he will certainly have you in awe and he will have you rooted to your seats, because when he delivers lectures, it's always precise, to the point, and very sharp and incisive. And I should also mention, I think, almost I'm telling his CV, I think, his interest in telemedicine took him to a different level and initiated the telemedicine program. And I remember once there was a very, year on year there's a conference on telemedicine which is being conducted, where I had the opportunity to deliver a lecture once in Hyderabad. And I realized that the potential of telemedicine which we see today was actually foreseen more than 15 years ago. At that time, technology was very meager, minimal, but with that technology, what could be achieved? And with today's available connectivity, what more can be achieved? And that's what is there, Ganapathy, for you all the time ahead of his time. So sit back, enjoy the 25th ALND oration by a stalwart in this field, and thank you for inviting me for this function. Thank you.
I will be brief, but probably to introduce Professor Ganapathy, it requires an oration before the oration. So, my slides please. Yeah. He was the most successful physician of his time, Western medicine, very well to do. You should read his biography, which tells what his contributions were. And then you read that Sanskrit word, Bishak Ratna. He attained that in Ayurveda. So an ophthalmic surgeon, a physician, became this. This is the gentleman who not only donated funds to build the Madras Medical College Institute of Neurology, but also through the years of gave away that entire wealth which he created with his brilliance. He gave it away for different things. I can go on and on for what he did. So the Arogya Ashram Samiti was founded as a trust when the British took this doctor's Ayurvedic farm and ashram to form the tank factory for World War II. His entire fortune was gifted to the welfare of modern medicine, Ayurveda institutes, history of medicine institutes, and the Madras Sanskrit College. Now, Dr. Ramamurthy was benefited by this legacy, and he sustained that legacy and one of his students is this brilliant gentleman who told me once that he met him while he was walking into IIT, and Dr. Ganapathy gave him a lift, and that journey took him on a long road. The distinguished professor in Madras, Tamil Nadu MGR Medical University, Emeritus Professor, National Academy of Medical Sciences, Distinguished Visiting Professor, IIT Kanpur, Past President, Indian Society of Stereotactic and Functional Neurosurgery, Past President, former Secretary and Past President of the Neurological Society of India, former Secretary of Asian Australasian Society of Neurological Surgery, and he comes from an illustrious family. This is his childhood. I will go through this for the time. And as you see, he was brilliant from the very beginning. Madras Medical College, as per what I could glean, he was 16 years there, and then he says that 16 years without failing. So he did not fail in any examination. This thing. And he is a teacher par excellence. He started the first formal certificate course on telehealth technology in conjunction with the Anna University. He was a mentor for MBA scholars from Harvard Business School and Ross Business School, University of Michigan, the Yale University, and several globally renowned Indian universities. For the last 5 years, 90 senior managers from 32 different countries doing executive MBA at London School of Economics visit his department as part of an educational tour. During the last 40 years, he has presented more than 400 papers in national conference and 150 in international meetings. He's been with the department from the very beginning, as you can see him there in the corner. And in the workshops also, you can see him sitting in the first, is one of the earliest workshops in thing. He was my examiner when I landed up at CMC Vellore. So along with Professor Vedantam Rajshekhar, he was my examiner. And he had bought his laptop. He left all these models behind, and he was asking me all sorts of questions. A remarkable person in telemedicine, and has an eye for the future, an eye for the past, and he is very well entrenched in the present. You can keep on giving him epithets. He has been pushing the Apollo thing, signing an MOU with the IIT Kanpur for these first private universities, which I am hoping that one day we will see the IIT Madras and VHS as a first medical university soon. So this is a journey, and this is him with his parents, his children who are accomplished in their own rights, and his wife has been a remarkable fellow. I have met madam in all the conferences, and he was telling me that sometimes his presentations also she helps him out with. She is probably the main source of support for him. And ladies and gentlemen, I present my teacher too, Professor Ganapathy.
Yeah, where is it?
Is the printing?
The photo.
Yes, the photo.
Yeah. Thank you very much. I'm extremely grateful to the organizers for what I consider a privilege.
Just a minute, the material has to be presented.
Okay. The photo.
Next one.
My presentation.
Check also.
Can you switch off some of the
Yes,
lights?
yes,
At least these
yes,
lights.
check so it is changing or not.
Okay, fine.
Yeah.
It was in 2008 that I first delivered a Lakshmipathy Oration at the Institute of Neurology, Madras Medical College. The next year in 2009, it was at the National Academy of Medical Sciences. I am therefore particularly delighted, grateful, happy that I have had the opportunity to deliver a third Lakshmipathy Oration, a very memorable one being the 25th oration at the Voluntary Health Service. Suresh, thank you very much for your kind introductory words. You have always been and will continue to be forever a great source of inspiration to me. I don't think he has, whether Anil Pandey has already gone through what Lakshmipathy Garu has done, and from what I could see from the literature, he is obviously an amazing gentleman. Excepting for Dr. APJ Abdul Kalam, it has again been my privilege to know every one of the previous 23 orators personally, and I've interacted with every one of them. My interest in thanatology, as is called, the science of death if you want to call it, it's not just an art, started, as far as I can remember, as early as 1961. You'll forgive me if I become very personal, but I think it's very important to understand the background under which I chose this particular topic. I vaguely remember my grandfather passing away in 1961. 1966, August the 3rd, I don't know, obviously it's not a red letter day. It was a terrible day for me because I got the news when I was in 11th standard that my elder brother had died in a road traffic accident not wearing a helmet. That minute, I was 17 years old, that minute I decided I'm going to become a doctor and save the whole world. 1972, pathology exam, university exam, preparing for the exam, another phone call at 10 o'clock at night. My eldest brother, again a road traffic accident, again not wearing a helmet, and this was the news I got. I rushed to the Institute of Neurology, which was Professor Kalyan Raman's admission day. He survived for about 12 hours and then he left the world. With two brothers, my parents having lost two brothers, it was obviously a disastrous sequence. So I decided I will stay back in India with them, and I had the privilege that my parents looked after me till I was 55 years old. Over the last, from 1966 to 56 years, I probably as a guesstimate would have personally presided, not encountered, presided over at least 2,500 deaths in a public hospital, Madras Medical College, Standy Medical College, a corporate hospital, Apollo Hospitals, a trust hospital, Sundaram Medical Foundation, and maybe about 50 to 75 people, close friends, relatives, neighbors, etc., etc. So this has left an indelible mark on me. In 1995, Ravi Ramurthy and some of the others may recollect, when the Human Transplant Organ Bill was passed, I wrote an article on viewing the critically ill head trauma patient as an organ donor. You need to understand that in the 70s and 80s, 90s, head injury was the bread and butter, if you want to put it very crudely, of a neurosurgeon. And we used to encounter hundreds, literally hundreds of head injuries for various reasons. And the mortality and morbidity rate was very high in the 80s and 90s. This article which I wrote elicited a reaction which I never expected. I got letters from seniors, people 5 to 6 years senior to me, neurosurgeons, saying, what the hell are you doing? You are portraying a neurosurgeon as an organ procurer. It so happened, and it was a very tough time I had to undergo. The first multiple organ transplant in South Asia was facilitated by my patient. It was a very emotional experience for me. I wrote an article on this, and this did help create an awareness. So here again, and subsequently I did a little more of the literature, understood what death was from a philosophical point of view, from a neurobiological point of view, and so on and so forth. The first 5 years, from 1990, maybe 10 years, 1995 to 2005, I was extremely enthusiastic about brain death, gave many talks evangelizing brain death, and this was all pro bono because you don't get paid for certifying a brain death. So I must have certified about 150 brain deaths between 1995 and 2010. So this intrigued my concept of what is death. Suresh mentioned that cessation of breathing and circulation. Sir, that was probably true 60 years ago. Today, as I will show you in the next 10 minutes, it's almost difficult to say when a person is dead. It's become extremely complicated in 2023, and I foresee with ECMO, extracorporeal membrane organization and various other things coming, is going to become even more difficult. It is not just an irreversible loss of brain activity. The most important point I wish to convey is death is not an isolated event. All of us have given hundreds of certificates saying expired at 7:32 p.m. 16th January 1992. It is scientifically wrong. We start dying even when we are unborn. Even 5 months after conception, cells in the body start to die. Death is a continuous, ongoing process. For purposes of convenience, we have said that death occurs when all these things happen. Now, what is its relevance in today's world? 2000 years ago, Pliny the Elder said, "So uncertain is men's judgment that they cannot determine even death itself." In fact, the Greeks waited for 3 days before cremating or burying the body at that time. The Romans, for 9 days, they would cut a finger. Ghee would be put on the forehead of a person who clinically was apparently dead, because if the temperature was 99 degrees, 98 degrees, the ghee would melt. 2000 years ago, we did not know how to diagnose death. Now, as I will show you in the next few minutes, diagnosing death has become even more complicated. Vesalius found a nobleman getting up at postmortem. There have been several isolated anecdotal reports, and I understand that burying after 1800, there used to be an alarm. Those days there was no alarm, but there was a bell, and in several instances a person presumed dead rang the bell, and then somebody came and rescued him. So this has been the concept of death. Our own personal experience. I remember a day in Diwali day 1978, 9 deaths. As a postgraduate, I had to certify. Abdul Qadir Said was the DANS, Duty Assistant Neurosurgeon. At that time, I was very young, immature, not that I'm very mature now, but still. And I got so irritated and angry. It was 3 years after I got an MBBS degree. I thought, what the hell, I am a doctor with 3 years of experience. Abdul Qadir Said insisted on going to the mortuary, opened the zip, there was no zip those days, opened this thing and saw whether the patient was dead or not. He did not have confidence that I would have diagnosed death. Retrospectively, I think what he did was absolutely brilliant. So this was the thing. Massive brain hemorrhage during a wedding reception. Just think about it. I got for AVM Rajeshwari Kalyana Mandapam, I got a call. The reception was going on. Patient just slumped on the floor. There was no diagnosis at that time. We did not have this thing. Massive brain hemorrhage. How do you tell the girl who tied the thali a few hours earlier that your husband is gone? No more. So these are the sort of incidences we come across. A professor of surgery, Madras Medical College, multiple disseminated secondaries. This was not recently. How do you tell him that proton therapy, yes, it's advertised all over the world. You're only postponing the inevitable by giving you proton therapy. You've got deposits all over the body. Professor of surgery will not accept it. When it comes to you, then it's impossible for you to accept it. 92-year-old woman, this is actually my aunt. Can you imagine what it is? Bilateral stroke she had. And then we took her away from the ICU, we kept her at home. For 2 months she was unconscious at home. My cousin, 72 years old and 68 years old, every alternate day they would ring me. At last, after 2 months of being in coma, I said, okay, stop the Ryle's tube, take off the Ryle's tube. As for the textbooks, she should stop breathing in about 8-12 hours. She obviously had not read a textbook of medicine. She continued to be alive for 60 hours without an hour doing anything. It's impossible for us to understand what it is to see a mother like this, deeply unconscious, nothing you can do. You're helpless. So this is what the real world is about. We also have the other side. Professor Ramurthy taught me this. I remember a patient where the father was kept alive to complete the daughter's marriage. And you know, particularly in South Indian, in the Tamilian community, what is it if the father dies a day or two before the actual muhurtam, that poor girl is condemned. People will say that girl was responsible for her father's death. So we kept the father alive till the marriage is over. Terminally ill pregnant woman. But you move heaven and earth to keep that heart beating so that the baby can be delivered. So this is the real world. This is not really described. I would like to reiterate again and again that death is an ongoing process and not a moment of time. How many of us know that if you drop pilocarpine in a dilated pupil, the dilated pupil will constrict even 3 hours after irreversible cardiac arrest? How many of us know that a kidney is viable and that a kidney can function for 10 years, 20 years if it is taken within 30 minutes after irreversible cardiac arrest, and so on and so on. Skin graft, 24 hours is viable. Aorta, vascular grafts are viable 72 hours after the patient is in the mortuary. So what do we know about that? Do we really know whether when the cells die, what really happens? I think the more and more science and technology we have, the more we realize, the less we know. Nails and hair, of course, continue to grow. Determination of brain death, death by neurological criteria, particularly when there's an extracorporeal membrane oxygenation, has become extremely complex. Today we just don't know when to declare brain death or not. An article I published in Neurology India 5 years ago, I never expected the response to be this. As of yesterday afternoon, 26,534 times this article has been read online in Neurology India. The Google scholar says it has been cited about 32 times. This is the interest. And what was my message in the article published in Neurology India? An individual could be considered legally dead in one country but not in another. The criteria for diagnosing brain death or brain stem death differs from country to country. And you can see a paper published a couple of years ago how there are at least 10 differences in 10 different countries. Recently, the WFNS has formed, I just forget the acronym for that committee, it has formed a universal brain death declaration who are going into it, and hopefully in a couple of years this is going to happen. Another article I wrote of good death and neurological practice again has been viewed 3,500 times, quoted, etc., etc. So what is the message? What is it I'm trying to convey to? This is the era. The neurosurgeons of today are outstanding carpenters, yes, superb electricians. I mean, plumbing, they're able to, we saw this morning about endoscopy, everything. I mean, just remarkable. Particularly when I joined neurosurgery in 1975, and today, I mean, the whole world has changed completely. But somewhere along the line, are we not missing the wood for the trees? What constitutes good death? The present focus is on curing diseases. Medicalization is a word which is now being used. Medicalization of life has made dying well extremely challenging. Dying at the preferred place, relief from pain, psychological distress. Let's be honest. How many of us spend time trying to find out. I did not. When I was in the ICU, when I was in busy neurosurgery, I mean, it was nowhere as busy as you people, but even at that time, I spent all my time in adjusting ventilator settings and trying to find out whether the sodium has gone down, trying to look at reversible conditions which cause depressed conscious level. The entire concentration was on anatomy, physiology, pathology and reversing. Did I spend enough time talking to the relatives, the healthcare provider? Did I even try to find out what is it that he would have wanted? What is it the patient would have wanted? Did I find out whether they were covered by insurance? Did they have to sell everything they have to raise the money to continue to an ICU? Did I spend any of this for the healthcare provider? I honestly don't think I spent as much time as I think I should have spent. Yes, of course, every one of us do spend time. It's not that we are oblivious to that fact, but still we could have spent a little more time. Of course, your concept on death, your reaction to death is a function of time. The whiter my hair has become, the more time I now have to think about it, my attitudes change, my outlook, everything changes. I'm sure I would not have given this talk 20 years ago. Things would have been totally different. So you can see here, emotional support. Emotional support, the most wonderful brainstem glioma excision, the most fantastic radiosurgery procedure, micro neurosurgery. It's absolutely amazing to see these pictures. But do we understand what it is for a person, to a family to go through? How much emotional support from loved ones? The right to assisted euthanasia, I'll talk about this later. So knowledge of when death is approaching and what can be expected. Of course, we are, and what I was taught by Dr. Kalyan Raman, Dr. Ramurthy and all my other teachers was, we never say that, we always say the 5-year survival rate in a glioblastoma, 2-year survival rate in a glioblastoma is 10%. That is how I say, because I don't want to tell the family, look, 6 months from now, 95% are no more. I mean, this was then, maybe things are different now. But we are not honest. We think that the family cannot face it. I think that's nonsense. There is enough published data available today to think that Dr. Ramurthy's favorite sentence was, I remember, he said, the more your formal education, the less common sense you have. And I think he was absolutely right. I mean, we think that only people who have been to university are able to analyze, think. I remember when I was in Stanley Medical College for 6 years. Stanley Medical College is totally different from Madras Medical College. Madras Medical College is the elite. Stanley was the poorest to the poor. I tell a person, look, you've got a malignant tumor, ventricular shift, that you have to be operated. He will ask me questions which were never asked at Apollo Hospitals, a corporate hospital at that time. So it is totally wrong to think that education is necessary, formal education, technical knowledge is necessary for you to make a decision. So I think this is one place where withholding and withdrawing futile, life-sustaining treatment is the norm worldwide. This is all very nice to give a talk, it's very nice to make a slide about it, but how many of us in the real world do it? End-of-life management. I don't know, I am honestly out of touch from neurosurgical practice for several years now, but did we really discuss end-of-life management in detail with the family? Patients dying in hospital ward or ICU receive aggressive care. For centuries, for thousands of years, it has been taught that a doctor's primary vocation is to save lives. Ladies and gentlemen, I put it to you that in 2023, in 2025, in 2030, if I were to write the Hippocratic Oath, I would rewrite it and I would say in 2030 particularly, a doctor's avocation also includes in ensuring a good quality of death. I have been obsessed with a good quality of life. I'm not an aggressive, I never was an aggressive neurosurgeon like many others. So if there was an eloquent area lesion, I was more worried about post-operative deficit. I was obsessed with quality of life and took a decision. Maybe the decision was not correct. Maybe more aggressive surgeons would have been able to remove it. But how many of us were influenced by the quality of death? Quality of death is totally different from the quality of life, as I will show you now. Clinical practice requires judgment, wisdom and compassion, not just technical mastery of future-ready technology. I think this is very, very important. I don't know whether we are taught ethics, whether, of course, all of us learned this the hard way. I learned it over a period of 30, 40 years. Nobody taught me. I think exposure to ethics, exposure to end-of-life treatment, exposure to palliative care in neurology and neurosurgery at the beginning of your residency career will make a difference. Woody Allen put it very nicely when he said, "I'm not afraid of death. I just don't want to be there when it happens." This is the real world. This is what is happening. And look at this. Death asked life, "Why does everyone love you but hate me?" Life replied, "Because I am the beautiful lie and you are the painful truth." It's a painful truth that none of us are immortal, but we refuse to accept the fact. We all think, you refuse to accept the fact that you're as mortal as anybody else. So here you can see, giving comfort and peace of mind to the terminally ill, social obligations, etc., all help a loved one through the most difficult part of their life. Little or no pain. This, I think, is very, very important. I understand that there are some committees looking into it, but again I understand that morphine today, please correct me if I'm wrong, cannot be prescribed by an MBBS doctor. Pethidine, morphine can only be prescribed by an anesthetist or by an emergency medical doctor or specifically a pain relieving physician. Morphine cannot be administered legally in an outpatient setting. Pethidine cannot be administered legally in an outpatient setting, is only inside a hospital. Many governments in other parts of the world, many countries have realized this, have changed it, all that. A simple thing like this, the number of people who die with pain. What the hell does it matter if you get addicted to pethidine and morphine in the last 6 months or 1 year of your life? We have a misconception. We have an absolute misconception that they would get addicted to drugs. I mean, I know his life expectancy is another 1 year or 1.5 years. Why can't I at least give him a pain-free period during that time? When end of life is imminent, with consent, aggressive therapies, medications, interventions are stopped, yes, but care is never withdrawn. We make a big mistake of equating care to intervention. Physical intervention and care are two totally different things. I can take a patient off the ventilator. I do not need to do a tracheostomy, but my care for the patient will continue. I can care for the family, not necessarily in an ICU, but even in a step-down ward or even at home. This is very important. Bad death, of course, most of us may not come through it. This morning we read in the newspaper, the health minister of Orissa was shot with a gun. Now this would be called a bad death, because in bad death there is violence, severe pain, torture, dying alone, being kept alive against one's wishes, loss of dignity and inability to communicate one's wishes. This is the most tragic. You are dominant hemispheres involved, you have an infarction, you are aphasic, you are not able to communicate what you want with the person. The person at the other end A does not understand or understands it wrongly. The process of death sustains gratitude, belief that life is still worth living, and some hope. Excessive and futile treatments are not used just to prolong life. The quality of death is as important. Unfortunately, particularly when we are very young, we cannot accept a mortality. That is the major problem with most of us. We need to understand. Then once you have 10, 15, 20 years experience, you know in your heart of hearts that this guy is not going to survive. Why not be honest with him? Why not tell the family? Yes, don't tell them he's going to die in 2 months, but you can tell them that the 1 year survival rate is probably 5%. I don't know whether you're going to be in that 5% or whether you're going to be in the 95%. This is how I usually tell people. I tell them with glioblastoma, I say there are anecdotal case reports where glioblastomas have survived for 2 years. At this point of time, I do not know whether you are going to be one of those anecdotal reports. Put it like that. They are smart enough, they're intelligent enough to understand that what you mean, that it's unlikely they're going to survive for more than 1 year. If I knew today that I'm not going to survive for more than 12 months, my plan of action would be different. I would certainly do things in a different way. So I think that is very important. We need to communicate all this. I am not going through all this, but it was amazing to see how in the last 3 years, the post-COVID, COVID has changed entirely all over the world. Not only in neurosurgery, neurosciences, but in all other sciences. The number of papers, there was a PubMed publication which showed that, for lack of time, I'm not putting all that, which showed that the number of publications on good death, today it is so simple with Google Analytics, you will find the word good death itself was coined only about 12 years ago. The number of publications on good death has increased 25 times in the last 2 years. Thanks to COVID, people have become aware of what it is to die a miserable death in the present when the COVID was at its peak. And because wishes of the patient and the family must take precedence before using tomorrow's cutting edge technology. Wishes of the family and the patient must take precedence. Lars Lexel, the inventor of the gamma knife, which at that time was the world's most sophisticated technology, he said, a fool with a tool is still a fool. I think that's very, very important. Technology, in my opinion, is not everybody's opinion, should be a means to achieve an end and not an end by itself. When you have a hammer, everything around you looks like a nail, but it's an expensive hammer, much more so. With multinational companies, the pressure you are put to use that equipment, this equipment, that equipment, etc. So what? It has to be contextual. My favorite word, particularly in telemedicine, which I use 10 times a day, is contextual. What is suitable for a remote healthcare consultation under this particular plan or method may not be suitable for somebody else under a different situation. You need to customize, you need to tailor make. One size does not fit all. We cannot give you 10 do's and don'ts. No, that's not how it is. The world is totally different. I may take a decision today, 6 months later, I may take a different decision. So at that point of time, the right place, the right person, the right thing, you need to customize your decision and make it contextual to what you want. What are the major problems? First of all, this subject would not be a subject which more people like to talk on. We want to sweep it under the carpet. I mean, it's macabre, ghoulish. It's very bad to talk about death. Everybody wants to talk only about life. We are not willing to talk about death. Our laws do not permit patients and families to take control. We have poor access. I've already mentioned this. We just don't even able to get morphine because it's for the fear of it being misused. The Indian Journal of Palliative Care, they have done excellent work, and as you can see here, dying is inevitable, but a good death is not. It is entirely in your hands to decide whether you want to have a good death or not. This, the end of life communication. Now, this model has been suggested. Expect emotion and empathize. Remember, it is very hard for you have seen 100 deaths. You know what death is. But for the wife, it is the first death. She cannot accept that her husband is not going to be alive for more than a few weeks. So this is very important. Map the future. Ask questions. Given the situation, are there things you want to do? The bucket list is not, it's not a cliche. It is what we actually want. I belong to the 1968 batch of the Madras Medical College. All of us are 71, 72, that age group. It is remarkable to see how my classmates, every one of them who have been in the peak of their professional career, how every one of us have accepted the fact. We know that we are not going to be here eternally. So when we are still physically and mentally in a good state of mind, let's do A, B, C, D, E. So this is what we are doing, and we have got together like we never ever thought we would do in the future. Plan next steps. It has been very helpful to hear what matters to you, get the advice of the doctor and understand what he wants. Advanced care planning. Advanced care planning, I'll come to this a little more in detail in a minute. I think this is very, very important. I, for one, I'm very clear in my mind what exactly I want. I have told my near and dear. I tried my best to officially, have an advanced care planning, but unfortunately, the bureaucracy is so much. Luckily, a lot of things have developed in the last 2 weeks. Death Cafe, just look at this, deathcafe.com. If you people have time, just go into deathcafe.com. It is a corner for all of us to ensure that let's discuss death over a cup of tea, white tea. Let's discuss death with some nice black, double black on the rocks. And this is what you want. Death cafes, you can see, offer meetings, death over dinner movement groups. All this are very common in Western countries. I am not aware if there is a death over dinner group in India. And today, with augmented reality, virtual reality, augmented virtual reality, extended by etc., 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 you know exactly. Here is a patient with terminal lung cancer, multiple deposits. He knows exactly that he's not going to survive for more than 6 weeks. And look at this lady. Obviously, she's 75 or 80 years old. So using all modern technology, she tries to understand how the other world will be, what is going to happen, etc. If Shakespeare had been alive today, even 450 years ago, Shakespeare said, "Oh, let him pass. He hates him that would upon the rack of this tough world stretch him out longer." If Shakespeare said this 450 years ago, what would we have said now? When is enough enough? Let go. That's the end of it. I remember I was in Germany for a conference. My father was 93 at that time, was admitted in ICU, Apollo Specialty Hospital. My wife called me. I took the next flight from the airport. I went straight to the ICU and I brought him home within about 2 hours. The junior doctor said, "Sir, what is all this? You can do that." I said, "I know my father. I know my father much better than you know them. Thank you very much. But I'm taking him home." 2 weeks he lived at home. He died with all of us present in the bed in which he had been sleeping for more than 40 years in that bed. This makes so much of difference to the patient, so much of difference to the family. Of course, the intensivists and critical care specialists won't like me at all if I advocate this, but we expect you to use your judgment for the individual case. Yes, there are hundreds of cases where intensive care can totally reverse the situation and the patient would have been lost if he had not been treated in intensive care. That is where your clinical judgment, wisdom, technical knowledge comes. You can see here, for everyone young, a catastrophic brain injury, there's no time to plan. Absolutely no time to plan. But here you can see, this is a very interesting, whatever I'm showing you here is based on solid scientific literature, PubMed index, peer-reviewed journals. None of these statements have originated from me. There's no originality here. I've only collated all the published data. For 85 to 90% of humanity, if you have 1.4 billion people in India, 90% of us can predict weeks or months before death is going to occur. I may not be able to say the day and the time, but I know based on my physical condition that I am unlikely to survive more than 1 year or 2 years. Trauma, of course, is totally excluded. Major myocardial infarctions, all that are excluded. But 85% of people, based on our medical history, we know to a reasonable extent how long we are going to survive. For cancer, again depends on the type of cancer, all this technical information, but we know based on the type of cancer, organ failure, dementia. Dementia, of course, it may be 15 years, you may be alive for 15 years. Neuropalliative care. This is a subject which I don't know whether the subject is included in today's MCS training program. This word did not exist when I was a resident. I don't know whether it exists now. Palliative care has to be customized, tailor-made. In my opinion, every consultant in every specialty, including dermatology maybe, has to be told what is palliative care in your particular specialty. You need to know when you call a palliative care specialist. Obviously, it's impossible for a neurosurgeon to learn the nuances of palliative care, but I should have enough background to understand that this patient requires a specialist palliative care. So this is very, very important. Now, indicators of end of life in neurological conditions. All this is common sense. I have just put all the data together. Rapid deterioration in mobility, rapid decline in cognitive function, difficulty in swallowing, respiratory failure, recurrent aspiration pneumonia in a 70-year-old or a 75-year-old. We have got to accept the fact that these are not good signs. Yes, it can be reversed. I am not saying be pessimistic at all, but be realistic and not totally optimistic all the time. At the height of the pandemic, Dr. Reddy made a public announcement. He said, of course, he mentioned this primarily based on telemedicine. Telemedicine has now picked up by almost 25 times. It has increased in the last 2.5 years. The government has, that's what is, I'm delighted. Most state governments now have a nodal officer exclusively for telemedicine. We ourselves have major contracts with public-private partnership. We do almost 20,000 teleconsultations every single day. 95% of this is for 7 state governments: Jharkhand, Chhattisgarh, Uttar Pradesh, Madhya Pradesh, Meghalaya, and so on and so forth. So this is the future, and the hospitals of the future are not going to be 1,000-bedded, 2,000-bedded, huge hospitals like General Hospital. This is going to be an anachronism. I foresee that 10 years from now, hospitals will be multi-speciality hospitals will become redundant. It will be single specialty hospital, because if I am going to do if an orthopedic surgeon is going to do a hip replacement, he wants a cardiologist opinion, I can get the cardiologist on my smartphone. In a couple of minutes I can get. So multi-specialty departments, I foresee, based on literature and little personal experience, will become a thing of the past. It will be a single specialty. Hospitals of the future will only be for procedures. Diagnostic laboratories will not be inside a hospital. OP consultation departments will not be inside a hospital. Follow-up will not be inside a hospital. Imaging will not be inside a hospital, and so on and so forth. It will only be for procedures. Everything would have been, anesthetic opinion would be done remotely. Everything would be, a patient walks into the theatre, gets the procedure done, couple of hours observation, and out he goes. So this is the hospital of the future, and this is what is going to happen. I don't know how many of you know that today, as per the census of India 2011, extrapolated to 2021, it's not an official census, but the census department does make extrapolation, scientifically valid. There are probably 1 million centenarians in India. Out of 1,000, incidentally, 2 weeks ago, the United Nations formally announced that India is the most populated country in the world. We have beaten China. Our population today is expected to be about 1,450 million people, out of which 1 million people are 100 years old. I operated on a 106-year-old person in KK Nagar in a small dilapidated nursing home. I took instruments from Stanley Medical College, 1996. Of course, there is a chronic subdural. Otherwise, I would not have done it. He lived for 1.5 years. His 80-year-old son and his 55-year-old grandson thanked me profusely when the patient removed the Riles tube, removed the Foley's catheter, removed the IV line, everything, and I got a call. So you use your judgment. To me at that time, a 106-year-old man who was in good health with a chronic subdural, just make 2 holes and let it out, I was justified. I obviously would not operate if a glioblastoma had been picked up at that time. The message I'm trying to convey is, we need to think that geriatric neurosurgical practice is going to be a part of all your practice in the future. Look at this, 96-year-old person seeks mercy killing. Mumbai couple wants euthanasia permission. Barbara and George Bush. You cannot think of anybody in this world who, more powerful than the President of the United States, even a former President of the United States. They could have converted their house into the biggest hospital in the world. They chose to die in peace, and they said, no more medical treatment, no doctor, nothing. Bush Senior. So Bush Senior and his wife, both of them died within 3 to 4 weeks of each other in the comfort of their own family. They said, we do not want medical attention at all. Assisted dying. Assisted dying was legalized as early as 1942 in Switzerland, in Belgium. For children, it was legalized in 2020, Netherlands, etc. You can see, I understand about 13 states in America, it's a state subject, so there it is legalized. 9th March 2018, a 5-judge bench of the Supreme Court of India said that the right to die with dignity is a fundamental right. Unfortunately, they also laid down some guidelines, which I'll come to in a minute. They laid down some guidelines, but implementing and executing those guidelines have become unworkable. And therefore, they went to court again. I'll tell you what happened later. Dying with dignity, I am not aware of such movements occurring in India, at least reported in the media, maybe somewhere here. But if you go through Western literature, everybody in most countries, and the developed countries, including Singapore, including South Korea, including Australia, New Zealand, etc., etc., these are the movements dying with dignity. It's your life, it's your choice. And dying is a process that can be influenced. The process of dying cannot be influenced. Deaths during COVID-19, I had to wear PPE, and I found it so difficult even to get into it for 10 minutes to visit my cousin who passed away, younger cousin of mine. And of course I had to use my little influence and my seniority and rank, etc., to get permission to go into the ICU. But after he passed away, the cremation, it was such a horrible thing. Two of us, we went. This was at the height of the pandemic. They would not allow the body to be cremated. And the best part was, I'm not even sure whether my cousin was COVID positive, because there was no proof that he was COVID positive, but this was at the height of the COVID. So everybody, they took the same guidelines for that. So COVID changed your views on death completely. Hopefully this is a thing of the past. I don't think this is going to happen again. The intensive part is over, and obituary notices, etc., have all become electronic. Funerals were held, online funerals were held, with people paying their last respects from all over the world, because physical funerals, the 10-day functions which we have, all that were not allowed. Living with advanced medical directives, and the Indians died badly. It is very sad. We are the Mecca of healthcare. We are better than the best. Whether it is ENT, whether it is neurosurgery, today I don't think there is a single procedure, including surgery of the unborn, fetal medicine. Suresh is a fantastic example. What little I know, fetal blood transfusion, intrauterine. Whatever you want to do anywhere in the world can be done in India. We have at least 100,000 people, as per statistics, every year coming to India from all over the world, including the United States, Canada, and advanced countries, for failed surgery in the US. I myself know of at least 10-15 people who had a repeat hip replacement for failed surgery. When that is our level of medical surgical, it's very sad that I'll show you in a minute. The Economist did a very detailed study. This was 10 years ago, and that showed that India is the worst place to die. I'll come to that in a minute. Instructions in a living will, we all know about do not resuscitate, DNR, but a living will should be a little more in detail. DNI, do not intubate. CPR, some people will say, I don't even want a CPR. I don't want a transfer to an ICU. I don't want organ tissue donation, tube feeding. I don't want a rice tube feeding, etc. This was a very complex. Again, some of my classmates and me, we wanted to give an advanced medical directive. I am very clear in my mind, when I am physically and mentally absolutely fine, I want to put down in paper, if I get this, don't do this. If I get this, yes, it could be a hyponatremia, and that could be corrected, and an unconscious person could become conscious again. So because of my background, technical knowledge, etc., we are in a position to do all this. When we tried to do this, we found it is the most horrible example of bureaucracy. You have to get it signed by a jurisdictional magistrate first class. Even though I've been in neurosurgery for 40 years in Madras City, I don't know who the hell is a jurisdictional magistrate first class. So just imagine the common man, what is he going to do? Two boards have to be constituted. The collector constitutes a separate medical board, hospital constitutes a separate medical board, and so on and so forth. Many of us were, but then we didn't have that passion, we didn't have that energy, or the wherewithal, or the documents, and the financial clout required to go to court. But people went to court, particularly the Indian Society of Critical Care. They were fantastic. Indian Society of Critical Care moved this. They showed the Supreme Court that for the last 4 years there has not been a single application for passive euthanasia, even though the Supreme Court of India said passive euthanasia is not allowed in India. So just 5 days ago, January 25th, the Supreme Court simplified the process, and today they have made it much more simpler, and I hope in a couple of months this will be effective, when many of us are really going to get this registered, so that an advanced medical directive is registered in the proper legal format. So here again, the Supreme Court benches, all this happened in the last 2 weeks. One statement was the center passing the buck by not deciding the issue of the living will. Now here again is a controversy. Health is a state subject. Even though the Supreme Court has given a directive, unless somebody goes for contempt of court, the local magistrate cannot do anything based on this newspaper cutting or based on whatever is uploaded in the Supreme Court website. The local magistrate, we met one of the magistrates and he said, sir, unless I get directions from the registrar of the High Court, we can't do it. The High Court judge who was also met, he said, I'm helpless unless the Principal Secretary, Health, Government of Tamil Nadu issues a GO and so on and so forth. But things are better now. Hopefully it will be satisfied. This is what I was talking about. The Economist is one of the world's leading, most respected magazines, and this was of course 2015. Things have definitely improved a little bit, but we were ranked 67 out of 80, a quality of death index. 80 countries, a very detailed study was done, and the most horrible place to die was 67. India was ranked as number 67. And you can see here what makes India one of the worst places to die in. Again, Abdul Kalam is an exception. But after the age of 50 years, less than 10% people die suddenly. You need to understand that if you take 1 million deaths above the age of 50, a few thousands only die suddenly. Even if it is a heart attack, nobody dies of a heart attack, first attack. He gets an ischemia, he gets something and so on. So what I'm trying to say is that you have enough time. You have enough time to plan what you want to do. Now here again, home alone. The number of people who are living alone. My parents looked after me till I was 55 years old. Now my wife and I, we stay alone. And we represent, this was becoming more and more. The last statistic showed still only about 7% of India at the time the study was done were living one person household. Whereas in Western countries you can see it is 40, 60, 70% and so on. So this is what is going to happen. Kerala is the most advanced state, not only in literacy, not only in computer literacy, but even in social achievements. They were the first state which passed a legislation to allow brain dead patients to take them off without family support. Now, the most important thing is, I don't know how many of you are aware that we legally, I'm talking of legally you cannot do tests for brain death. Simple thing like a caloric test, apnea test and all that, you cannot do that unless your purpose is to identify whether the brain dead patient is a suitable donor or not. If the family is not willing for donation, as per the present law, none of us practice it, that is different. As per the present law, you cannot get 3 people. Now even if I say this patient is brain dead, excepting in Kerala, legally speaking, you cannot disconnect the ventilator unless the family also agrees. Whereas in Kerala today, and this is a GO pass, the Kerala today, if in public interest, what is the point in keeping a ventilator on and occupying an ICU bed when a patient is already brain dead? So the government says, we have the authority to remove the ventilator once you are certified as brain dead. This well-dying law, this is what India needs. South Korea passed what is called a well-dying law, and they encourage it, and you can see here, when my time comes, I want to go in peace, thanking everyone and saying goodbye to my loved ones. So you can see here, these are the various countries, the Netherlands, France, etc. Most European countries have similar laws doing all this. In the Mahabharata it is mentioned, Yudhishthira said, day after day, countless creatures reach Yama's abode, yet those that remain behind believe themselves to be immortal. What can be more extraordinary than this? This was a statement made 5,000 years ago. We refuse to accept the fact that we are not immortal, that we are going to be eternal. I could go on and on, but I think I will stop with this. So what is my take-home message? The real question is not whether life exists after death. The real question is whether you are alive before death. I think this is very important. We need to understand that you have the right to decide how you want to make the final journey. I may not be able to decide from where I'm going to make the final journey, with whom I'm going to make the journey, when I'm going to make it. No, but I have a right and I need to plan right now. I need to plan right now how I would like my final journal to be made. I know this may sound macabre, ghoulish, this may sound insensitive. Many people here may think, what the hell, this guy is talking about death, aren't there? Isn't anterior clinoid excision much more? Isn't clipping a basilar artery aneurysm? Absolutely fine. Clipping basilar artery aneurysm is thing, but then maybe when you become 72 years old, you know that you have lived more time in the planet. None of us, even if my life expectancy is 90, I'm not going to live for another 72 years. So we know that. We know it's either 5 years or 10 years or 15 years or 20 years, but that is it. So I think the time has come when and at a personal level, I have told all my near and dear very clearly, I don't want a tracheostomy, I don't want intubation, I don't want A, B, C, D, E. And once all these things are over, many of my classmates, we are planning to get an advanced medical directive actually done. So once again, thank you so much. So it has been a privilege and an honor, and I think I forgot to thank Ravi. Ravi gave me a nice photograph which I showed, the first one, and though I don't know Dr. Lakshmipathy, it has been my privilege to know his daughter who delivered both my children, to know his son-in-law, my teacher, and to know his grandson with whom I have been a classmate in 1967 at the Loyola College. So thank you Ravi, thank you Vasudevan, thank you everybody, and whether anybody benefited or not, I benefited by putting all this together.
Thank you, sir. Can I request Dr. Krishna Kumar to give a vote of thanks? Everybody, please join us for lunch. It is upstairs. Everyone, it's a request that you come for lunch. And after this, we will have a photograph of the faculty and the delegates here itself, and then we'll go for lunch. Dr. Ravi.
Imagine knowing this man from 1967.
A great level of tolerance he has, so he has put up with me for 55 years.